Hi, good afternoon, everyone. Myself, Dr. Suman from Zydus Medical Affairs. I once again welcome you all for today's Interact Masterclass session. So, first of all, thank you so much for joining in on time on Saturday. And for today's topic, we have nasal angiofibroma, a very interesting topic. And we are going to interact with stalwarts in the field of ENT, and we are going to understand more on that. So, without ado, the session, as you are aware, our course director, Professor Dr. Dwaipan Mukherjee, sir, he will be the program director for this event, and we have subject expert, the stalwart in the field of ENT, and an innovator. We have Dr. Satish Jain, sir, and for moderating this session, and also he is for part of this entire ENT masterclass event. Dr. Deepak Haldipur, sir, he will be moderating today's session, and as panelist, we have Dr. Vikas Agarwal, sir, who is again a renowned ENT specialist and expert in the field of obstructive sleep apnea. And also we have Dr. Mahesh Kumar Vikram, sir. We'll just quickly take a quick intro like about them. Okay, Dr. Dwaipan Mukherjee, sir, he is a professor and HOD for ENT, KPC Medical College and Hospital, Kolkata. He's the immediate past president of Association of Otorhinologists India, consultant in Manipal Hospital, director of Spiral ENT Clinic, and trustee board member of AOI West Bengal, and is recipient of major KK Ghosh Award. And also, this slide is not enough to elaborate his achievements. And I welcome you, sir, for today's session. Next, we have our speaker and another renowned ENT expert, Professor Dr. Satish Kumar Jain, sir. He is a senior consultant ENT, head and neck cancer and skull-based surgeon, Jain ENT Hospital, Jaipur. And he has more than 2 decades of experience. He has performed more than 150,000 ENT surgeries and is renowned for removing even the most advanced stage tumors. He has done pioneering work in the development of endoscopic and microscopic skull-based surgeries. He has revolutionary work in the treatment of angiofibromas. He has developed interlay technique of tympanoplasty surgery and also developed convergent approach to identification of facial nerve in parotid surgery. He also initiated cochlear implant program in Rajasthan, which has helped lots of children regain their hearing. And apart from this, he has done a lot of research work, and also he has a lot of publications, and he has won many awards. Okay, like the slide is not enough to describe that. And I welcome you, sir, for today's session. And next we have Dr. Deepak Haldipur, sir. So he's a senior ENT consultant. He is associated with various renowned ENT hospitals across Bengaluru. And he is also honorable ENT consultant at Indian Institute of Science. He is specialized in microsurgery of ear, endoscopic sinus surgeries, rhinoplasties, microlaryngeal surgeries, head and neck surgeries, cochlear implant surgeries. He has also delivered various lectures when it comes to field of ENT across the country, and he is also member of various renowned ENT societies of India, and his research is published in various national and international journals. I welcome you, sir, for today's session. And next we have Dr. Vikas Agarwal, sir. He is certified robotic sleep apnea surgeon, Mumbai, and he has expertise in obstructive sleep apnea and also is an expert in the field of ENT, and he is part of IAOHNS, and he's performed the first robotic tongue-based surgery for obstructive sleep apnea in India, and is the first to webcast live robotic tongue-based surgery in the world, and is first to describe the boundaries of dissection in adenoid surgeries. And he has a lot of fuss in his resume, and this is not enough to describe it. And these are few pointers, and he's discovered the role of salpingopharyngeal folds in the OSA and published its classification system. And he pioneered and published a novel technique for palate surgery for snoring and sleep apnea and suspension bridge pharyngoplasty. And he has won various awards. He is part of various national and international ENT associations. I welcome you, sir, for today's session. And next we have Dr. Mahesh Kumar Vikram, sir. He is Associate Professor, Dr. Vasant Rao Pawar Medical College, Hospital and Research Center, Nasik. He has won Best Director Lad Skull Base in 2026 at Dandi Skull Base Foundation, and he's a member of Association of Otolaryngorhinologists India and also Indian Society of Otology, and he has various publications in national and international journals. I welcome you, sir, for today's session. I'm really excited and honored to have all these renowned faculty in today's session, and looking forward to the session. And I welcome you all, and now I hand over the session to Dr. Dwaipan, sir. Over to you, sir.
Good afternoon, all. First of all, I'd like to thank Dr. Suman for this elaborative introduction of all the faculties. Now, in nutshell, I can give you a glance of this program. This is ENTERACT Masterclass. We had 2 sessions of ENT Masterclass. First one with Dr. Ravi Ramalingam and the second one with Dr. Deepak Haldipur. And now today's session is with Dr. Satish Jain, legendary ENT surgeon in this field of nasopharyngeal angiofibroma. The flow of event will be like this. Dr. Satish Jain will deliver his deliberation on nasopharyngeal angiofibroma for 35 to 40 minutes. In between, if you are having any questions, you can send those questions. After the deliberation of Dr. Satish Jain, we will discuss all these questions with our panelists. That means with Dr. Satish Jain, Dr. Vikas Agarwal, and Dr. Mahesh. And the entire Q&A and panel discussion will be moderated by none other than Dr. Deepak Haldipur, director in the Class 12 Hospital in Bangalore. And this ENTERACT Masterclass will be continued throughout the year, each and every month. So the next session will be held on 12th September, and on that day the subject expert will be Dr. Amitava Raichoduri, and the topic will be the phonosurgery. So without wasting any time, I like to request Dr. Satish Jain to please start his deliberation.
Thank you, Dwaipan. Thank you so much. And I am rather indebted to the team AOI for, propagating academics like everywhere. And we are so grateful to our president and dear friends, and especially Dwaipan for making this happen. He is, we all know, tirelessly involved in propagating academics in our country. Thank you, Dwaipan. Am I audible there?
Yes.
Yes.
And big thanks to, and what a great opportunity to meet these legends, Dr. Deepak Haldipur, Dr. Vikas Agarwal, Dr. Mahesh Nikam, and everyone. We all know they have, made their mark everywhere in this field of otolaryngology by their legendary work. And I have been blessed to have opportunities many times to learn from them. Thank you, Deepak sir. Thank you, Vikas. And thank you, Dwaipan, for everything. And thank you, Team Zydus, for arranging all this. So today's session, like Dwaipan said, will go by 30 to 40 minutes on this topic of JNA. We all know JNA. Anything before that, Vikas, anything you want me to say before I go ahead?
I mean, you are the subject expert on JN, and everybody knows that. I'm actually waiting to learn from you.
Come on now. You know everything, nothing for you. Anything new for you is, I don't see. But anything, it's a great opportunity for me as well to, discuss with you all. So I hope my presentation is there on the screen.
Yes. Yeah.
So
we can see Satish. Yeah.
10 minutes we'll discuss about what we want in the JNA management. Next 10 minutes, the workup, what kind of workup we need to give a proper treatment, and then we'll discuss the surgical part. So JNA, we all know, is a complex subject, and the only reason is its propensity to bleed profusely. The reason is the architecture of the tumor, which contains only vascular tissue, and that tissue which has no, elastic lining for the vessels to contract, and it keeps on bleeding profusely. And that is the fear among surgeons, particularly when tackling with the endoscope to control that massive hemorrhage. If not managed, can create havoc. So In JNA, all JNAs are not same. We need to know certain things about JNA, propensity to spread, how these JNA typically spread, and the complexity. So the challenges are in decision making, first reaching correct diagnosis. Sometimes we get referred, so many patients with a nasopharyngeal mass in a child assuming JNA, may not be JNA always. We need to confirm before, contemplating any surgical procedure, all that. And the perfect thing for the diagnosis, preoperative diagnosis, since there's a vascular lesion, the biopsy is never advocated. It is the radiology which substantiates the diagnosis, because certain pathway spread of JN is typical to this tumor, and that is how radiology can pick up easily this vascular tumor. Then the question of embolization, the surgical approach to choose whether open or endoscopic, and a so-called recurrence. This is a benign tumor, it cannot recur, but we see a lot of recurrences which are actually not true recurrences. It is actually a residual tumor which was left behind during previous surgery and can regrow. So all these issues need to be addressed when we discuss JNA. So the radiology, the key thing in the management of, overall management of the JNA is the radiology in terms of reaching to the correct diagnosis, in terms of what all the radiology gives us, how to reach to the correct diagnosis, whether it is JNA or not. It is always by the radiology finally. Number two, since it is a vascular tumor, what all vessels are supplying the tumor. So you have to plan the control of those vessels, and that is again dictated by the proper radiology and angiogram, which I am going to show you. Then how these vessels are entering into the tumor, so surgically you can accordingly handle them. It's not always the vessels are running the same course and can, complicate the situation. So that you should know on yourself by means of an angiogram how the vessels are entering the tumor, so you can actually take them under control properly. Then where the tumor is extending, so you can plan your surgical approach. Most of the JNA, JNA has a tendency to spread by advancement, by compression. This tumor arises here in the region of the sphenopalatine foramen and grows circumferentially all around by expansion, not by invasion, not by destruction. It is always a pressure destruction of the surrounding structure wherever it comes in contact with. Any bone particularly, it comes in contact, gets destroyed, but not by means of true invasion, a primary JNA. And that's what we need to pick up from the radiology, where the tumor is extended, so you can plan your surgical approach. And most of the time, primary JNAs, wherever they are extending, most of the time, majority can be accepted by the endoscopic approach, not because it is an advantage that you don't need you don't finally give a scar or anything. That is last in terms of priority. There are certain advantages of endoscopic approach by means of, this approach is more useful in the primary JNAs. Revision JNA cases where the primary blood supply is taken care of earlier and the patient develops, some other blood supply, other feeding vessels which are not predictable, can make the tumor more aggressive, more invasive, or sometimes truly invasive tumor even into the brain we have seen. So JNAs are all not same. We need to see from radiology that what kind of tumor exactly it is. So the first thing what I want to show is the radiology. In JNAs, what I'm this one. Yeah, I hope you are getting MRI on the screen. I'm sure you are getting the MRI
Yes,
on the
sir.
screen. Yeah,
Yes, sir.
let me.
Yes, we are getting the MRI on the screen.
See how this tumor, I'm not going in details of the radiology at this point of time, but want to show tumor actually spread in a preferential manner. This tumor arising here, it goes preferentially in the posterior part of the nasal cavity. It goes preferentially laterally through the pterygomaxillary fissure in the infratemporal fossa. It goes preferentially behind, destroying the pterygoid plate, and through the pterygoid plate it enters into the sphenoid sinus, never through the natural ostium. And from there, this enters into the superior orbital fissure, inferior orbital fissure, superior orbital fissure, then behind to the cavernous sinus. By means of eroding the sphenoid, the temporal floor, it can extend right into the middle cranial fossa. So it can extend anywhere by means of a pressure destruction, and that is what you need to know from the radiology. And this kind of a preferential spread of a tumor, completes your diagnosis of a JNA. So radiology substantiates your diagnosis, number one. Second information, what you need to know in every case is the vascularity, because it is the fear in the JNA surgery is all about vascularity. See this tumor, how it is spreading everywhere, this vascular tumor, destroying the pterygoids on the CT angiogram. What we actually need to know is the vascularity, which vessels are supplying this tumor so we can catch them. Our radiologists can tell that the internal maxillary is supplying, but how the internal maxillary is entering is a big question. So what we do, we read our angiogram ourselves, and this is what we always propagate. And I can show you quickly. See this, if I go in the lower part of the neck, this is the internal carotid artery. This is the external carotid artery going behind where my cursor is. And this external carotid is dividing into branches here. This internal branch, this one is the internal maxillary. See this vessel where I am following is the internal maxillary. And this is the principal vessel which is entering the tumor from behind. This is the posterior wall of the maxilla. And this is the pterygoid process. This is the pterygopalatine fossa. And this vessel enters the tumor from behind, coming to the posterior wall of the maxilla. See, this is the vessel. This is the vessel which is coming here, just behind the posterior wall of the maxilla. And this makes the principle of endoscopic surgery, resection of this tumor easier. How we approach this tumor, we all know this is a vascular tumor. If you enter into the tumor without taking vascularity in control, it's going to bleed like anything. So what we do, we go by the anteriorly by the modified Denkers, by removing the anterolateral wall and the medial wall, reach to the posterior wall, and immediately behind the posterior wall is the vessel, because this vessel is always anterior to the tumor. And this, because in the pterygopalatine fossa, this vessel runs in the most anterior plane. This tumor arising from behind, which pushes the vessel more anteriorly, makes it further traceable. The moment you remove the posterior wall, the first structure you see the vascular network of internal maxillary supplying the tumor, and that is where you need to vascularize before you enter into the tumor. So on angiogram, you can get to know where the vessels are entering into, which other vessels are supplying. We have many times the vessels coming from behind into the tumor. Many times we have, the ascending pharyngeal entering into it, middle meningeal branches entering into it. And those cases, you can't control those vessels without entering into the tumor, because they enter from the tumor into the tumor from behind. And in those situations, the embolization has a role. Otherwise, in our clinical practice, most of the time we devascularize the tumor intraoperatively to minimize the bleeding, and rest of the bleeding on the surface. At the surface has maximum vascularity, we control with a coagulator to make the field good, and can remove this extremely vascular tumor endoscopically without compromising with the visualization. So you have to plan according to the vessels entering into it. You have to plan your embolization accordingly, and then you can handle the tumor accordingly. So this is something to everyone, which we always propagate to understand this, how these vessels enter into the tumor. Now, coming to the PowerPoint. Huh? To the screen here. The PowerPoint.
फोल्डर से निकाल
JNA
का फोल्डर खोलेगा डाउनलोड्स में
नहीं the PowerPoint is here now. Come on. Here I am. So what we were discussing about the sources of bleeding. So another myth that embolization can really be very, very helpful and devascularize the tumor completely. may not be correct always. The reason being, to understand in the simplest manner, the sources of bleeding to this tumor maximal through the external carotid branches, mainly IMA, then could be from the internal carotid artery branches, particularly when it extends to the skull base. Sometimes even not extending to the skull base, sometimes the median artery may be a principal vessel and the venous bleeding. And out of all these, embolization doesn't work on the venous bleeding, on the internal carotid bleeding. You cannot embolize only the external carotid feeders, which is principally the internal maxillary artery responsible for most of the bleeding, except for bleeding coming from the opposite side once it does attachment in the nasopharynx, which we take care during surgery. Majority of the bleeding you can control intraoperatively without embolization, unless that vessel is coming into the tumor behind. That is the only thing. Other things to reduce the bleeding are controlled hypertensive anesthesia. Coagulation is our key. We call it as a man of the match most of the time during surgery in these patients. Lastly, what kind of approach you should choose? This is always a big question. Even in the biggest JNAs, primary JNAs, still you can remove the tumor endoscopically by doing a planned division. Planned division means whatever tumor in the nasal cavity part, midline, you can remove first, dividing the medial part and removing that, allowing the lateral tumor to accommodate in the nasal space after the medial part removal. That's how even the biggest of the JNAs can be removed. The only issue where the endoscopic approach has a limitation is massive facial extension, which you cannot, as a volume, you cannot cater into the nasal cavity. Intracranial vessels coming onto the tumor. If you try to remove the tumor from below, it can avulse the vessel and can give intracranial bleed. That you can see on the angiogram. And thirdly, the major vessel encasement, particularly in the revision situation. In the primary situation, even if the carotid is involved, mostly there is a intact periosteum over it and still you can peel the tumor off. But in revisions, you have to be careful. And in that situation, you must get a DSA done. Test the cross flow. If the cross flow is good, you can, in a case of complete 360-degree involvement, you can take a call of pre-operative coiling of the carotid to take the tumor completely out. So indication for the open approach are in certain situations still exist, and we should take into consideration in those situations rather taking every case endoscopic. Recurrences, believe me, as I said earlier, this tumor is a pure benign tumor like any other benign tumor. If you remove completely, it cannot come back. Recurrences happen when the tumor is left behind and it regrows. Actually, it regrows, and the most important reason is inadequate assessment. If the tumor involves the skull base, the greater venoid sphenoid, pterygoids, all those critical areas, the sphenoid bone, the Haversian system of the sphenoid bone is frequently invaded by the tumor. And if it is not assessed properly on a good MRI, fat suppressed MRI, you can overlook that involvement. You can leave the tumor behind and it can certainly regrow. So adequate assessment and planning on basis of radiology is the key. Marrow infiltration. The sphenoid marrow classically has a affinity for this tumor to grow in, and that kind of, if marrow infiltration is there, a fat suppressed MRI will tell you, and you can drill away the complete marrow bone in that region to ensure that no tumor is left behind. If tumor has a significant ICA blood supply with a lot of bleeding, that bleed make you miss the tumor. You have significant, for any other reason, intraoperative bleeding may even not allow you to see the tumor completely and can lead to a blind procedure, and obviously the surgical experience. All these matters in terms of avoiding the recurrence. Now, coming to the surgical part, surgery in JNA is always oh, come on, let me share this. We have our pattern of, which we always propagate to remove this JNA more efficiently endoscopically. Let me give you some. Now, coming to the surgical part, what I'm trying to show you. I hope my video is being shared now. This kind of a tumor, let me show you. Now, the surgical part. What we do in surgery, we have to get a good paramedian corridor to reach out the tumor laterally. See this tumor lying in the posterior part of the nasal cavity. You have to decongest the nasal cavity well. And the biggest obstacle is this lateral nasal wall. I am just quickly following the video. This is the lateral nasal wall, this tumor on the left side. What I am doing, coagulating the mucoperiosteum of the lateral nasal wall, simply to minimize the bleeding. Coagulation is the main tool. See, you can minimize the bleeding, and by means of ablating, you can remove this lateral nasal wall so effectively. See this? How effectively one can remove this lateral nasal wall without giving bleeding. This lateral nasal wall being completely, this mucoperiosteum being removed, and the bone being exposed so that we can remove the bone to get into the maxillary sinus head on. That's the lateral nasal wall. This is the inferior turbinate. This is a separate bone. Has to be removed along with the wall of the maxilla. That's the inferior turbinate. And this is the inferior meatus. This is the nasal floor. So we have to remove this entire lateral nasal wall until the nasal floor. See this entire nasal wall being exposed, the medial wall until the floor. Just quickly showing this. This is the entire medial wall after removal of the periosteum. Now we move on to the anterolateral wall. This is the piriform aperture. This is the anterolateral wall. The medial wall already denuded of periosteum, the bone exposed. Now the anterolateral wall as required for a paramedian exposure. It depends upon how laterally the tumor is growing. If it is too lateral, you can go up to the infraorbital neurovascular bundle. This is how the removal of the lateral nasal wall. Now entering into the maxillary sinus. Again, you have to be careful not to go too high up to damage the orbit. Orbit is our upper limit. So now we are not going high up in the orbit. And what we are doing, I am just making an opening to show or see within the maxillary sinus to know the level of the roof. This is head-on opening into the maxillary sinus. See, this is entering into the maxillary sinus with a 0 degree through the anterolateral wall endoscopic. Denker had described this approach long back by the sublabial route, and this is being modified, this is being modified endoscopically by the Stunman and Canfield, and this is how this is modified Denkers. You can go completely endoscopic. Now, once you have seen the opening, you know the level of the roof, keep widening with a high-speed drill. This is a transnasal angled burr working at a 60,000 RPM, and you can really widen this opening. Widen this opening. See this entering into the maxillary, posterior wall of the maxilla behind. Thinning the medial wall so you can punch it out. The only critical structure here in the medial wall is the nasolacrimal system. This is the nasolacrimal duct you can see in medial to the suction here. And that is what needs to be handled to prevent epiphora. Superiorly, you are supposed to flush with the floor of the orbit. So actually we cut this duct sharp at the level of the orbital floor. If you cut the duct below the level of the orbital floor, it keeps overhanging and can get fibrosed. And that is something which gives a permanent epiphora which is not warranted. So see the level under vision, the level of the orbital floor. Until that level, you remove the medial wall completely. Now see the medial wall being completely removed, and the structure next is the nasolacrimal duct. See, there's a wide opening. You need to take this opening down to the floor down to the floor for your better instrumentation, and remove medially, completely flushing with the floor of the nose. Quickly. You can use chisel laser also to expedite, but the drill is more precise, it is more useful. Now see the medial wall, the remaining thinned out medial wall, you can punch it out and see what is there behind is the nasolacrimal duct. That is the nasolacrimal duct. That is the critical structure in the modified dankers you deal with. And to prevent an epiphora, we will skeletonize till the level of the roof of the, the maxillary sinus to the level of the floor of the orbit. See everything behind the duct, all around the duct, it is skeletonized. I am fast forwarding in between to finish in time and see how the duct is, entire bone is opened up till the floor of the orbit. This is important, which I am emphasizing to prevent an epiphora. Otherwise, patient come to us, post-operatively sometime to with this presence of epiphora, which can be certainly avoided. That is how we have adopted this technique of flushing with the roof. Flushing. See the duct flush with the floor of the orbit. You can little pull it, so you don't allow it to overhang after cutting, and you can cut it sharp. Cut with the sharp scissors, and this is where the nasolacrimal duct is. So now see the duct. It doesn't come in our view for the future course. The duct doesn't come in the way. Now, flush this medial wall posteriorly till the posterior wall. Flush this medial wall completely to the posterior wall. The posterior wall mucosa being removed, and the area of interest is in our view. That is the posterior wall of the maxilla. Behind that is the pterygopalatine fossa. This posterior wall of the maxilla should be skeletonized, should be in front of you. This is the turbinate medially, middle turbinate. This tumor has an affinity to take attachment onto the turbinate, onto the nasal septum, and we have to devascularize all these attachments of the tumor. Wherever this tumor takes attachment, it acquires new blood supply. So we have to be careful in devascularizing that. Now, more and more exposure of the posterior wall, the turbinate being coagulated, this turbinate gives attachment to the tumor medially. Now, the posterior wall, more and more exposure of the posterior wall. Now we have to remove this posterior wall. Bigger the tumor, the posterior wall is more and more thinned out, anteriorly bulging, easier to remove. You can remove by the drill, you can remove by the chisel hammer. See how the posterior wall being removed. Going fast forward, this posterior wall, more and more exposure of the pterygopalatine fossa periosteum. See, behind is the pterygopalatine fossa periosteum. All the time, you should make the efforts to flush this medial wall till the posterior wall of the maxilla. So this is the tumor. This is the tumor. There should not be any intervening bone remaining between the tumor, various tumor parts. All bones should be completely removed. See, all bones should be completely removed. This is the nasal part of the tumor, and this is the infratemporal fossa part of the tumor with no bone intervening. Bone is an obstacle. Bone is an obstacle. Now see, more and more the turbinate removed, better exposure medially. This is the tumor in the inferior part here, the nasal part of the tumor. And this is all the pterygopalatine fossa, bone, and the periosteum. Above is the ethmoid sinuses. Now see this, the pterygopalatine fossa being exposed, the bone being removed. Thorough bone removal. This again depends upon how extensive the lateral extension of the tumor is. But remove this. Now, behind this bone is the periosteum. And behind the periosteum, the first layer of structures are vessels, the internal maxillary architecture. From CT angiogram, we can actually make out at what level the internal maxillary is from the level of the floor of the roof. You can actually gauge in millimeters on CT angiogram where exactly you are likely to find the vessel. So you don't, keep looking for the vessel, keep searching for the vessel all the way and keep giving bleeding. Can you see this? The moment you remove the posterior wall, you can see the glimpse of vessel architecture. All these are branches of internal maxillary. If you see any single vessel, you can follow it back to the internal maxillary core. The main, see the internal maxillary vessel with its branches. From here, it gives branches to all the connections of pterygopalatine fossa. See this? This is the internal maxillary and this lies on the tumor. Tumor is behind it. So that is the biggest advantage of endoscopic approach. When you approach it from anteriorly, the moment you remove the posterior wall, the first structure you come across is the vessel and to prevent a massive hemorrhage. And that is the basic principle of endoscopic surgery. And you can simply apply a couple of clips to ensure that this vessel doesn't reopen in the post-operative period. Clips are the best material to ensure that see the vessel lying laterally and the tumor is medial to it. This is all tumor which is medial and behind to it. Now, this is major devascularization. This doesn't mean that the tumor is completely devascularized. We have not done microvascular, microtumoral devascularization, which can be achieved by a very, very good embolization, which is not warranted. But see the amazing view, amazing visualization with endoscope with hardly any bleeding. And you have to keep doing by means of a coagulation all the time. That is the basic principle of this surgery. Now, once you have achieved this posterior exposure, you can go around the tumor, go above. See this ethmoidectomy to remove all the cells above to see the tumor is not going entering into the ethmoid. This tumor sometimes reaches high up to the ethmoidal roof. So you have to define your upper limit. Medially, this is your middle turbinate. See this? And this is the nasal septum. And this tumor takes attachment to the nasal septum, and by means of coagulating the periosteum, you can devascularize the septal attachment. You can easily devascularize. So wherever it is attached to the periosteum, it acquires blood supply. If it is attached to the nasal septum, it acquires sometimes contralateral blood supply and devascularizing this further, reduces the tumor vascularity. And see, this is this is behind in the sphenoid sinus. Just behind the middle turbinate, medially is the sphenoid sinus. This tumor doesn't enter the sphenoid sinus or never enters through the ostium. So what you see this, the sphenoid sinus being widened from below, and this tumor which is there entering into the sinus, you can see very well. So you can widen the sinus opening to take it down. See this, above is the sphenoid sinus, you can see carefully. See, above the sinus and in the floor is the tumor. While removing, you have to simply take this tumor down. This tumor doesn't take attachment anywhere to the sinus mucosa. It preferentially doesn't take any, characteristically doesn't take any attachment to the sinus mucosa. You have to just pull it down by opening the sinus wide. See the interior of the sphenoid, and this tumor is rising into the sphenoid from below. This is the interior of the sphenoid, and you have to simply pull it down. So this is superior exposure. The sinus towards the sinus side. See laterally towards the lateral nasal wall, this tumor, and this tumor is going from here laterally further in the infratemporal fossa. Here this tumor is going laterally here. So all these exposure are required. Now the posterior exposure. Posterior exposure is equally much. You have to go behind the tumor and transect the contralateral blood supply coming to the tumor, or the tumor attachment from the nasopharyngeal roof, which is giving additional blood supply to the ascending pharyngeal and other vessels. Every vessel gave bleeding or contribution to the bleeding into this tumor. So principle is, before entering into the tumor, we have not entered the tumor from anywhere. We are devascularizing from all around wherever it is expanded. This tumor extends by expanding. See now, the posterior septotomy posterior septotomy going behind to the opposite side. See, gone to the opposite side nasopharynx. This is the nasopharynx across the, septum to the other side of the tumor. And this tumor is now completely occupying the nasopharynx. So all intervening, compartments have been cleared off, making a single piece of tumor in your view everywhere. See, this nasopharyngeal roof attachment should be thoroughly coagulated. This is the floor of the sphenoid sinus, and here is the roof. Above the adenoids, this periosteum give attachment to the tumor. That is important attachment, driving blood supply from the opposite side and other vessels, the pharyngeal vessel, and should be devascularized. Once then, it is packed. Now the tumor is, from all around, it is exposed. This is the lateral component. This is the medial component. This tumor from here grows everywhere, into the pterygoids, into the greater sphenoid, further up, through the orbital fissures into the cavernous sinus. It doesn't enter into the cavernous sinus through the sphenoid sinus. It is always through the orbital fissures, which is continuation of the cavernous. Now see what is being done. Since there is a lateral component, so our policy is divide the tumor. This is bipolarization first at the level of the lateral wall of the maxilla. The lateral wall, at the same level of the lateral wall first, this bipolarizing to further devascularize this attachment. This is the tunnel between the medial and the lateral part of the tumor, which is being further coagulated, and then we'll use the coagulator to divide this. This tumor being divided like cutting the butter. See, absolutely bloodless. This is JNA being cut literally absolutely bloodless, because we have taken the vascularity from all around in control before entering the tumor, and now at the level of the lateral nasal wall, the tumor being divided. See this tumor being divided completely. This is lateral component. This is medial component. Medial component from the sphenoid sinus, nasopharynx, from everywhere it is made free. And now at this point, after dividing this, see this division, the medial and lateral component with hardly any bleeding. One cannot imagine we are dealing with a JNA without embolization. And this, if you follow the principle, you can actually do it. Now see what is happening. Once you try to remove the medial, mobilize the medial component, the important attachment goes to the, this is very important in the pterygoid process. See this tumor entering the pterygoid process. See this. You have to pull it. If you leave even the smallest microscopic of the part of the tumor, it can regrow. Gentle traction from the pterygoid brings the tumor out. See this tumor coming from the pterygoid bone. See this, the bone of the pterygoid. See this spongy bone of the pterygoid with venous bleeding coming immediately. This venous flow shows the tumor being completely removed, and we should not try to overpack it. Just allow the blood to flow for a while, and you can then pack with a Surgicel so that you don't pack the tumor component. See, this pterygoid process tumor under vision being removed. There is no other way. That's the biggest advantage of endoscopy, that you do everything under vision. Quickly, we are approaching our time limit. So in 5 minutes, this is how the tumor being removed from the pterygoid process. Now this entire medial component of the tumor has only attachment left is in the ipsilateral nasopharyngeal loop side. Tumor and cut with the coagulator and take it out completely. There is hardly any attachment left after this. Just pull it out of the sphenoid. See the tumor being pulled out of the sphenoid easily. This is venous bleeding, which we don't intend to pack tightly at this stage. This is healthy bleed. Allow it for a while, a little bit of the bleeding, so that you don't overpack the tumor after removal. And this entire tumor getting out. See, the entire medial component is getting out in no time. And then you can pack. This is the final attachment being severed at the level of the eustachian tube, ipsilateral. And then you can either bring this tumor, so if it is big, through the oral cavity, Once it is completely freed, you can bring it out. See now the tumor is completely free, and then you can pack the nasopharynx. That's how the tumor is out. See this? You can bring it out. Now the lateral component. Quickly, the lateral component is left behind here. After removing the medial component, the advantage is now you have ample of space to accommodate the lateral tumor. Since your vessel is already in control, see the vessel on the surface, retract the vessel, this tumor goes by expansion. Similarly, you have to pull it into the nasal cavity. So now lateral component, whatsoever big it is a cakewalk to remove it. It is so easy to remove the lateral component once the medial component is removed. See this traction and counter traction. Everything is all about traction and counter traction. This coagulation being used as a for the traction, and your instrument is pulling, the coagulation is pushing, coagulating the fascia interface. The vessel is lateral here, this is internal maxillary, and lateral component, no time you can remove the lateral component, no time. From here, if it is going to the superior orbital fissure, you can pull it. If it is going to the cavernous sinus, you can similarly you can pull it. Whatever extension into the middle canal fossa, everywhere the primary tumor goes by expansion, and similar way, by the same principle, you can remove it in no time. That's how the principle of JNA is. And then finally, you check the pterygoid process. If any tumor left behind, you can drill it off. That is where, see, it is the pterygoid bone. This is the cancellous bone of the sphenoid, this spongy bone, which can harbor the tumor, microscopic residue. You can completely under vision with a diamond bar, you can completely, drill it off under vision to ensure that no tumor is left. This is the commonest site for the tumor residue, and this is the orbital fissure component being removed now. See this? Again, traction and counter traction. Traction and counter traction. This is going into the orbital fissure and going further to the cavernous sinus. And by means of traction and counter traction, you can easily pull it out. So whatsoever a sort of difficult looking tumor extensions are actually easier after this approach. It is the modified Denker which matters. Remove the medial component and then you can pull in whatever the lateral component wherever it has gone, and drill the underlying bone so that you don't leave behind any tumor residue. Even if you leave a microscopic, it can regrow to a bigger tumor labeled as so-called recurrence. See this? This tumor is going into the superior orbital fissure and the cavernous sinus. The V2 there down, and see how this tumor is being pulled out of the superior orbital fissure and the cavernous sinus. This is the last part of the tumor. See the tumor coming from the superior orbital fissure and the cavernous. So all crevices, any open approach cannot give this kind of exposure to pull this tumor from this narrow crevices, foramen and fissures. That's how the endoscopy scores over the open approach. It is not the scar which matters, doesn't matter. If any approach after giving a scar gives better outcome, I'll opt for the scar rather than the endoscopic approach. See this how this tumor completely out now, and now you have a good normal bone underneath, and that's how you see the complete tumor removal. So thank you very much for your attention. I know I'm just exceeding the time limit. So any questions now, or anything, any suggestion or anything you want me to show more? Because it is endless otherwise.
Thank you, Dr. Satish Jain. So now I like to request Dr. Deepak Haldipur to pitch in. He will be the moderator for this question answer session.
Yeah. Am I audible?
Yes, sir.
Yeah. Satish, in today's era, you can tackle 90% of these things by endoscopic.
Yes, sir.
So what are the ones where you decide against endoscopic? What makes you decide?
I mentioned if you have notice the slide I purposely mentioned.
Yeah.
The three regions. Let me share with you again.
Yeah.
3 regions for the, say this, which makes me think of an open approach. Number one is a massive facial cheek extension, the voluminous tumor which cannot be accommodated through the nasal cavity. If I give you example, we have some terrible extensions, unbelievable, which cannot be delivered endoscopically. Number one. Number two, in certain situations where the tumor is coming far anteriorly out of the anterior nares. How will you accommodate your instrument, your endoscope, and all those things without entering the tumor? And that's how the purpose is defeated. If you try to enter into the tumor at the beginning, it is going to bleed like anything.
Yeah.
Those situations you have to think of some other approach. Third is intracranial feeders. We have lot many patients having lots of intracranial feeders coming. If you want me, I can show you certain examples where the patient having intracranial feeders and it is difficult to handle those situations. If you try to pull the tumor from below, the vessel can be avulsed and keep on bleeding intracranially, which can be a disaster. So a pre-op CT angiogram is decisive in those situations if you have massive arterial feeders from the MCA or other ICA branches from intracranially. And fourth is a major vascular involvement. If I have a particular revision situation, 360-degree carotid involvement, I have to think twice with the endoscopic, which you cannot manage the laceration of the carotid endoscopically, as effectively as by the open approach. In those situations, the DSA is required, a cross-flow test is required. If possible, a pre-op coiling, which we have done in a couple of cases, and control the carotid before preventing the laceration and remove the tumor, even endoscopically. But sometimes, if that is not possible, you have to go by the open approach.
Yeah. The other question is, in today's era,
Yes, sir.
do you really embolize any angiofibroma at all?
Yes. I mentioned, see, this internal maxillary being the principal source of bleeding runs anterior to the tumor.
Yes.
And that's an advantage. You go behind the posterior wall of the maxilla and the first structure you come across is
The
internal
IMAX. Yeah.
Look at the CT angiogram I showed earlier. I can show any angiograms where the principal vessel is ascending pharyngeal, coming into the tumor behind. How do you control the vessel without going through the tumor, without entering the tumor? And those are the situations. We have seen tumor high up in the infratemporal fossa acquiring additional blood supply from the middle meningeal. How will you control the vessel without entering into the tumor? So those are the situations where you can't control the vessel before entering the tumor. You have to do embolization. And third is the situation in revision cases where the primary blood supply, the predictable blood supply internal maxillary is already taken care of by the previous surgeon. And the patient develop unpredictable blood supply. Other feeders from the external carotid which are difficult to catch otherwise. And then you take the advantage of embolization. Embolization is not a straightforward thing. I tell you, it looks so fascinating. We have even got a lot of tumor embolized. What you need is a very, very experienced neuroradiologist, interventional radiologist. They have to make sure that there are no dangerous connections between the internal and external carotid. Otherwise, whatever you embolize can get embolized in the internal carotid circulation and give in the lots of intracranial complications. They have been reported.
Yeah.
And third is microvascular embolization. Embolizing the stem of the internal carotid, which is internal maxillary, is not an end artery. The embolizing material should reach to the microvasculature level, and that is where the experienced intervention radiology is required. A liquid embolization. Nowadays, the Onyx is one of them, which you can directly inject into the tumor and make it avascular. The cost is a limiting factor. So many things are concerned. Sometimes the embolization is much more costlier than the entire surgery. And like in the previous case, if you follow the surgical principle by taking the vasculature in control all around before entering the tumor, in the last case I had shown, not even a single unit was infused. There was less than 100 ml total blood loss. by means of adopting a surgical approach in a way you can devascularize the tumor. You can devascularize the surface by means of a coagulation. You don't actually need embolization very often. And in primary tumors, whatsoever extensive they are, most of the time their extension and blood supply is predictable and you can control without embolization.
Dr. Haldipur,
Now
yeah,
I request Vikas Agarwal and Mahesh.
Dr. Haldipur, there
Yeah.
are few questions from the audience. We can take opinion from Dr. Vikas Agarwal and Dr. Mahesh also. What to do when there is torrential bleeding intraoperatively and the tumor plane becomes difficult to identify? Dr.
So,
Vikas? Yeah, Dr. Mahesh.
yeah, when there is a torrential bleeding, the first thing either you use cautery, coagulation, or the main thing is packing. Keep the pack, localize the bleeder, and then use a bipolar, unipolar, or coagulator. Main thing is packing. Pack with the roller pack. Wait for some time, and then assess the where exactly the bleeding is there, and then do the needful things. And on embolization, I want to add something. As Satish boss has already told, there is no role in embolization for expert. But those juniors want to start their practice doing angiofibroma, they can think of doing embolization in their initial practice. When they become an expert, they are like afterwards, there is no need. They will find that embolization have don't role while dissecting the tumor, because initially, as first thing which we do is to catch the IMA, and afterward it become simple thing to remove the JNA. So in my opinion, those who want to start their JNA practice, they should try embolization in their patients so they become much more confident during the removal of the JNA. And second thing, while doing the JNA for newcomers or younger people, always do the wide exposure first and then touch the tumor. Thank you.
Any comment from Dr. Vikas Agarwal?
I totally agree with Dr. Mahesh Dayapan.
Yeah.
He said in the end, the exposure. You saw in the surgical what I demonstrated. My 90% of the time was invested in exposure. Right from modified dankers to exposing from all around the tumor removal took less than 10 minutes. So exposure, the skull base, overall in the skull base surgery, when you try to reach out the deep-seated tumor, you have to expose rather than working in a keyhole to give complications. So exposure is the key.
So any comment from Dr. Vikas?
Yeah. So my first case in private practice back in 2003, this was July 2003, was angiofibroma. And it was referred to me by Dr. Ashish Bhumkar, right? And I did a sublabial excision because that time endoscopy was not that much in vogue and I was also not experienced. So it called up Dr. Kirtane, sir, tomorrow I'm doing my first private case and that's an angiofibroma. He said, go ahead and do it. Nahi samjhega to just take a lateral anatomy approach. So this again makes the point that exposure is the key. I was ready for a lateral anatomy. Consent was taken. But with sublabial, with a 40 ml blood loss, I could complete the surgery. This was 2003. Now, coming to the answer of if there is a torrential bleeding. See, what you do when a complication happens will depend on why a complication has happened. So again, like Satish said, that you have to first approach the tumor from outside, take over the blood supply. So back in those days also, the approach was that we approach the tumor from the outside. Say sublabial approach, lateral anatomy approach gives you a lot of space. You can go around the tumor and pack from the laterally. Obviously, we could not use the coagulation in those days, was not available. But that's the whole thing. If a bleeding has happened, you have to first understand from where is the blood coming. Because if you blindly try to pack here and there, nothing is going to happen. Suppose I remember a case where everything I had done beautifully, no bleeding. And while taking down the posterior extent, there was a bleeder from the back, like Satish said. I did not know during those times that, okay, such a situation can happen. It was a embolized tumor, but obviously that vessel was not embolized well, and it was a vessel from the back, and that started bleeding. And I spent almost 2.5 hours only to control the vessel from the back. So the answer is that you have to understand the supply very well before doing. One thing I have added in my practice, I do not do too many angiofibromas anyways, but I have added, and I'll ask Satish's opinion on that, use of piezoelectric. So with piezo, you can go more aggressive on the bone, because then there is no fear of a bleeding from happening even near the carotid. You can just use the piezo very, very effectively. So rather than the drill, when I use the piezo, and that too, Sonopet is a very fast piezo, that really makes my life much simpler. Anything to do with the bone which is in vicinity of a very critical structure, like carotid, like optic, piezo is a great device because it will not damage the soft tissue. So these are the things that I would like to add apart from what has already been said.
Dr. Haldipur, over to you. Dr. Haldipur?
Questions?
Yeah.
Dwaipan, are there any more questions?
Yes. Another question. How to approach JNS with intracranial extension, particularly when the tumor is closely related to the cavernous sinus or internal carotid artery?
Yes.
Yes.
Satish
Yes.
and Mahesh and Vikas. Yeah.
I think let Satish answer this question. He will answer it.
See, intracranial extension is of varied types you can see in JNA. In a primary situation, it is almost always intracranial extradural tumor. Intracranial but extradural, because it goes intracranial by eroding the skull base. And those are the simplest situation. Even if the cavernous sinus is involved, you have seen this tumor, last part of the tumor which I had shown came out of the cavernous sinus. It is pushed inside, so you have to pull it out. You have to widen the entry by means of drilling the bone all around, and gentle traction, you don't break it and pull it out. So even the massive intracranial extensions going into the middle cranial fossa or cavernous sinus, there is almost always a plane intact plane between the tumor and the dura, and you can almost always pull it out. Problem happens to occur when the high rising intracranial tumor acquiring additional blood supply from the intracranial vasculature. I can show a lot of angiograms or patients develop additional blood supply from the middle cerebral arteries coming down to the tumor in the middle cranial fossa. In those situations, if you try to avulse the tumor from below, can invite or can avulse the vessel and can give hemorrhage in the intracranial portion, and that can be a disaster. So the intracranial extension, how extensive it can be, it depends upon how it is expanding and how it is acquiring the additional blood supply. Thirdly is the revision situation. Revision, you have to be very, very, careful. You have to treat the revision tumors differently, particularly invading the deep skull base and intracranial. They are almost always invasive. We have seen the deep tumors in the intracranial space, revision tumors, truly invading the brain. Not only dura, but truly invading the brain. In the revision situation, acquiring massive intracranial blood supply from the internal carotid feeders make the tumor more invasive. And we have witnessed those, and those tumors requires an open approach along with the endoscopic one. So depending upon the intracranial extent, you have to choose the approach. It is not the extent. Even a massive intracranial tumor with no intracranial additional blood supply, with no invasion of the dura, still you can pull it from below. And we are doing it on a regular basis. So it depends upon how the tumor is invading and how the additional blood supply is being derived by the tumor to choose the approach between the endoscopic and open.
So there is another question from audience. Is the goal of surgery always complete radiological clearance, or is it okay to leave a small residual tumor in selected high risk locations?
See, this is a benign tumor. The only cure is complete removal. There is no place for leaving a tumor behind, that too deliberately. There is no space. If you leave the tumor behind, it is going to regrow and going to give much more challenges than a primary tumor. So, and this is how the endoscopy scores. That is how the endoscopy has got popularized, because in open approach, what would we do? We remove the tumor, it bleeds like anything and pack immediately. It doesn't give you opportunity to inspect all the foramina and fissures where the tumor can go inside. This endoscopy you have seen with a brilliant illumination and on-site magnification, with a good gentle traction, you can remove the tumor from all these areas. If there is bone infiltration, pterygoid bone, whatever, under vision, you can do a drilling, complete drilling to remove the tumor. That opportunity cannot come with an open approach. So, leaving tumor behind has no place in any given situation.
Satish,
Yes, sir.
when would be the ideal time to do a follow-up scan to look for the residue?
See, most of the time in our practice now, we have stopped doing follow-up scans unless we have doubt about skull base clearance. Many a times, I can show you video, tumor at a complete adherent to the carotid canal. We adherent to or deeply invading the callus bone of the sphenoid or the clivus. In spite of the complete clearance of that, but mostly after doing this modified dankers, it gives an opportunity to inspect the cavity always in front of you rather than getting radiology done unnecessarily. So most of the time, if we have a gut feeling that we have a complete clearance, complete without any breaking the tumor into pieces, remove the tumor completely, there is no need of follow-up scan. But yes, in deep-seated tumor, revisions, piecemeal removal, any doubt on the clearance from the cancellous bone of the sphenoid, if you have any slightest of doubt, yes, follow-up radiology is important, and it depends upon the healing and the symptoms it gives post-operatively.
When would you do it if a follow-up is to be done?
Nothing before
Ideally.
6 months. No
Okay.
radiology before 6 months.
Okay.
In less than 5% cases, we order post-op radiology nowadays. We don't need radiology.
Okay, so we have passed 15 minutes, over and above 1 hour, and I can share with you already before half an hour, we have crossed 2600 registrations for today's program. I like to thank each and everyone, and I like to request to give a final comment regarding the program and regarding the subject. I will start it with Dr. Vikas Agarwal.
I think it's a great concept, Dipan. Webinars are the future because you do not have to come and sit at one particular time. And this small 1 hour window between our, say, operative time in the theater and OPD in the evening, it's a great time to choose. And obviously, a subject expert like Satish or what we have Ravi in the past, it's a fabulous concept, and I completely agree. And I wish you continue it forever.
Dr. Mahesh?
Yes, sir. Definitely a good move actually. And for junior people like us, it's a definitely encouraging, and we learn from the experts like Satish was. And these are the topics which you choose are definitely helpful in your routine practice. And the youngster will definitely get it much more knowledge from this lecture series or webinar. Thank you to you, and should continue throughout the year. Thanks, sir. Thank you.
Dr. Satish Jain.
I have no words to express thanks to you. And it's not today. I have always seen Dwayapman in the forefront of propagating academics. Not only this, I can remember 10 years, 15 years back, so many workshops in Kolkata and everywhere. He is the one who is always in the leading this. And thank you, Dwayapman, for enlightening us by your thought process. And I am today, believe me, I am the biggest beneficiary. Sharing the knowledge is the biggest way of learning. And I believe that when you are doing great job. Thank you so much.
Thank you. Dr. Deepak Haldipur.
Really grateful, Dwaipan, that you have made me the moderator in all these programs. It gives me a chance to interact with the legends, learn as usual, and also keep abreast with the knowledge. And I've always believed that this is the media that is going to be in future. When traveling becomes so difficult and all that we need to do is spend about an hour and a quarter on a Saturday afternoon, once a month, 12 meetings a year, we can cover all topics.
Thank you. So I like to request Dr. Suman from Jain to give vote of thanks. And we will again meet on next 12th September for the 4th edition of ENTERACT Masterclass. The topic will be phonosurgery and the subject expert will be Dr. Amitava Raichaudhary. Dr. Suman.
Sorry. Yeah. So once again, good afternoon. Thank you so much. And really, it was a pleasure to see all the stalwarts having discussion on such interesting topic. And I was really amazed and it was really enriching. And I'm pretty sure all the audience who have joined today, it can be PG students, it can be practitioners, experts. So they have a lot of take-home messages today for their practice. And I'm pretty sure it's gonna enhance their clinical practice even further. And I thank all the Dr. Dwaipan sir for being the core part of this event and personally taking care of everything. And our speaker, our moderator, and our panelists for giving their time on Saturday and giving their 1 hour and talking about nasal angiofibroma. And that's again like the next event Dwaipan sir has told like when it will be. And thank you all for joining in. And thank you once again. And hoping to see you in the next session. Thank you, Dwaipan sir. Thank you, Mahesh sir. Thank you, Vikas sir. Thank you, Satish sir. And thank you, Deepak Haldipur sir. Thank you. And thank you all the audience.